Well, good morning, and thank you for being with us this morning. This talk is one that comes from some of the feedback that we've had in the past. What do we do with ulnar-sided wrist pain? So as Duran said, we do listen to your feedback. We do appreciate it. At the end, it gives us some ideas of what to talk about in future years. Now, because this is a very, very broad topic, if you look at your handout, there's a whole lot of subtopics in this. I'm going to cover a lot of these very quickly, but I will spend some time in a bit more detail on a few points in there, just on the areas that I think are missed often or a little bit more complicated. Not everything will be covered equally. But the problem here on ulnar-sided wrist pain is often the diagnosis is actually very difficult to make. There's a lot of structures very close together, tendons, nerves, ligaments, joints, bones, all very, very closely packed, and it can be very difficult to distinguish one from the other. And because of that, the treatment plan is also very difficult. Because if we can't find an anatomical cause of pain, it can be very difficult then to form an appropriate treatment plan. So, we want to try and break this down to a very simple approach. I did manage to find a very simple flowchart published in a journal earlier this year. I'll give you 3 seconds to look at this. And there it is. Let's try and make it a little bit simpler. Key to all treatment is the accurate history and examination, right? As orthopedic surgeons, we love to grunt at patients. So I had to learn how to talk to patients when I was starting to deal with this. We need to know not just what the history of the pain is, but as you know, what are we trying to get the patients back to? Because the reality with ulnar-sided wrist pain is it often grumbles on for a long time, and it's not quite solvable 100%. And so we need to know how much effort are we going to put into this to get this patient to a level that they're comfortable with. How aggressive do we need to be in treating? When we examine the patient, we want to be very precise in our examination as well. So I'm going to give just a quick 2-minute demonstration on how I examine someone who comes in with ulnar-sided wrist pain. I picked our youngest and fittest member of our group.
Youngest, maybe.
to demonstrate this on. And this is not a comprehensive examination. It's just targeting the part that I'm interested in here. Okay? So, camera guys, I hope you've got enough field of view here. What I do normally is I'll sit the patient down, we'll sit opposite each other, and I'll either sit at the corner of a table. Actually, can I come over here to get this out of the way? Is that all right, camera people? Yeah? Okay, you'll tell me if there's a problem. Oh, you can't see me? Well, you can't see me because of this. I'll go and stand here because I know there's a camera looking at this. Okay? So, what we're going to do now, what I'm going to do is sit down. That lags by 30 seconds. Okay, so what I'm going to do is sit down in front of the patient. Normally, I'll stand for this demonstration, and I'll just do a quick screening. Okay, so I get the patient, just do what I do. Okay, I'm screening for elbow and shoulder from the front and down, and I just want to see whether they can place their hand in space. I get them to supinate fully, and I'm looking for any bumps, lumps, scars, and that sort of thing. I'm checking range of motion. And when I'm in this position, I will grab their hands and just tweak the supination a little bit more, because classically a TFCC tear has increased pain on the ulnar side of the wrist when you supinate fully. I'll get them to turn around like this, pronate, and I'm looking for an ulnar bump, ulnar head bump, and then do this, and I'll just quickly check the wrist range of motion. Now, when it comes to palpation, this is where a lot of the importance is in being very precise with the examination. I will start on the radial side of the wrist and I'll work my way ulnarwards because I want to know at what point it starts to hurt. I'm going to palpate the distal radius, I'm going to palpate the radiocarpal joint. The DRUJ is dorsal here. You can palpate the ulnocarpal joint, and you can move around to the ECU tendon. Any fractures will be picked up in direct palpation of the bones here. Now, to get to the volar aspect of the wrist, you could do this, but this causes pain in certain patients. And so what I actually do is I'll get the patient to, we're sitting, remember, either use the armrest or the corner of a table, put the elbow on there, and I'll do it in this position, so it's neutral forearm rotation. And I will, just turn around this way, I'll start on the radial side and work my way across ulnar again. We'll get across to the FCU tendon here. In the FCU tendon is the pisiform bone, where you can palpate for pisiform fractures or pisotriquetral problems. And now if you fall off the FCU tendon just ulnarwards, there's a soft spot there at the end of the ulnar. That's where most TFCC tears are felt. That's called the foveal area. Now, the special sort of tests for this, with the patient relaxed, I will stabilise the radiocarpal joint. We hold the distal ulnar, trying not to cause pain in the grip itself. I'll rock it back and forth to get an idea of DRUJ stability. We do that in pronation and supination as well. While I'm here, I'll grab the forearm and I'll move the hand ulnarwards, and we'll get an idea whether squashing the structures on this side hurts as well. That's a TFCC test. While you're in this position, hold that position. I will put this hand here and get them to ulnar deviate against me. That's an ECU test, and you can do that while pronating and supinating and check for subluxation. That's my general screening test. Thank you. And we will modify that a little bit depending on exactly what the patient requires. That then allows us, by now, in about 90% of cases, to have formed a diagnosis. And so investigations are then really only there to confirm the diagnosis, not to make your diagnosis in most cases. When you go on to investigation, it is important to pick the right imaging modality. And the most important imaging modality for this is an X-ray, even if you're suspecting a soft tissue problem. And that's because the X-ray gives you an overall view of the anatomy. I will come to the importance of this later on in some of the specific conditions. Very rarely an ultrasound is useful. That's usually for things such as ECU tendon subluxation, or for clicking, where you're trying to determine what's clicking. And as you know, CT scans are more useful for fine views of bones, MRIs for soft tissues. Now, an important investigation for me is actually injections. And we often think of injections as treatment and therapeutic, but it's a very important diagnostic tool because you have so many structures nearby. Sometimes we're not sure exactly what it is. And so an injection into structure A, which takes the pain away, more or less confirms that this structure is the cause of your pain. Whereas if injection into structure A doesn't, then now we need to look at B, C, D structures to find out what it is that's actually causing the pain. The other important thing about injections is you must set your expectations right for your patient. Because patients will often come in and they'll say, I had an injection, it didn't help. Well, their expectations may not have been right from the first place, because injections are very rarely the end cure. They're usually a step on the way towards a cure. The drug itself doesn't last forever in the system. And so eventually the local anaesthetic's going to wear out, or the steroid's going to wear out. Something else needs to give the long-term relief. And that's usually where you guys step in, right? With your supervised exercise programs and other treatments. The injection allows that step to start so that they can start your treatment without pain. And then when the injection wears out, it's everything else that is kicked in. But like I said before, unfortunately, ulnar-sided wrist pain is sometimes a little bit like back pain. It's hard to treat, it's not straightforward, it takes a long time to get better, and often it grumbles along and can be aggravated even months or years down the line by certain activities. All right, that's my overview. Let's go on with a few conditions. And like I said, I'm going to skip through some of these quickly and others we'll spend more time on. We'll start with acute injuries because this is relatively fast to get through. They're easy to diagnose. The history is pretty obvious. Patient's fallen over, injured themselves, or whatever it is. And for these ones, yes, you do need investigations. The X-ray is useful, but sometimes a CT scan is also needed. So if we're looking at fractures, for example, in this picture, it's fairly obvious that there is a fracture at the back of the wrist. Further X-ray views will show that this may be, as in this example, the triquetrum. Now, the treatment for these flaked sort of fractures off the bone is essentially treating them symptomatically like a sprain, as long as the wrist is stable. So this is where your examination comes in, and if the wrist is stable, there's no dislocations or instability when you examine the wrist, treat them with a splint, move them as they get better, and treat the whole thing as if it's a bad sprain. However, sometimes you'll see X-rays like this, where there's a triquetral fracture, but it's not really clear what it looks like. Now, this patient has a wider trauma. I'm using this as an example. There is a scaphoid fracture here as well, and other issues. A CT scan of this one is needed because it gives us more detail about the actual fracture. It's a through and through fracture. This triquetrum is structurally compromised, unlike the previous one, where just a small flake was off the bone. These ones need fixing. As I said, this patient's got more than just a triquetral fracture going on. The other type of fracture that often needs a CT scan are the base of the fourth and fifth metacarpals. These are easily picked up on X-ray, but if you've got an X-ray of these and it looks like it comes near the joint, it is wise to send for a CT scan. And that's because a lot of these fractures into the joint come very close or are associated with a subluxation or dislocation of the joint that is not picked up on X-ray. This particular one was displaced and shortened enough that it was worthwhile fixing with K-wise. Other fractures around the area, distal ulnar fractures, quite obvious if you palpate that area and it's sore. I won't go through treatment of this because it's very fracture dependent. But interestingly, distal radius fractures can cause ulnar-sided pain as well. And that's because despite the radius fracture being on the radial side of the wrist, on the ulnar side, the fracture can go into the DRUJ, where that yellow arrow is, or if the radius is shortened, the ulnar becomes prominent and can cause an impingement or abutment where that purple arrow is up the top right. In general terms, earlier treatment for carpal fractures then is indicated if there's a stability issue or a structural problem, okay, such as that triquetral one. The bone needs to support something else. These are probably best discussed with a nearby surgeon or colleague, and hopefully you've got links into them. Now let's go on to some chronic injuries. These are a little bit more complicated than acute injuries because there's often no clear precipitating factor or incident. And so it becomes a little bit harder from the history to determine the cause, to determine which anatomical site is likely to be involved. Sometimes it's just overuse. The patient may just not be built for the particular activity they're trying to do, and that makes it very difficult. One common cause of ulnar-sided wrist pain is the TFCC. Now this, of course, can be injured in an acute injury as well. The TFCC is a structure here in red. It stabilizes the DRUJ, and in this particular MRI, the yellow arrow indicates a tear at the periphery of the TFCC. The general treatment of someone who comes in with a TFCC tear starts with you guys if it's a chronic condition, or even if it's an acute condition where the DRUJ is stable. And that's a system of ulnar-sided strengthening, proprioception, and so on. The most important investigation here is actually not the MRI scan, it's the X-ray. And that's because what we're looking for on the X-ray is the overall anatomy of the wrist. In particular, is the ulnar longer than the radius? Because if the ulnar is longer than the radius, then that could indicate a problem with ulnocarpal abutment, where the lunate is carried proximally by the shorter radius and hits up against the distal ulnar, squashing the TFCC that sits between them. In this situation, treatment is often indicated in the form of an ulnar shortening osteotomy. Here's an example of a TFCC repair. A peripheral tear such as this can be repaired surgically if there is DRUJ instability in an acute injury, or if there is ongoing pain not responding to non-operative management. It's done arthroscopically. The middle picture on the right shows the yellow arrow indicates the TFCC, and the green arrow in both pictures, I think that's green, yep, shows the peripheral tear with some sutures that are about to be tightened. In the situation of a long ulnar, an ulnar osteotomy brings the distal ulnar away from the lunate and gives it a bit more breathing space. So on the left is preoperatively, on the right is postoperatively, and you can see now that the ulnar is a little bit more proximalized, taking some of the pressure off the TFCC. Now, another difficult problem that I've found in wrists is arthritis. And in general terms, hand and wrist arthritis, the patients often come in and say, I've got arthritis, there's nothing you can do about it, is there? Well, no, there actually is. Okay? I don't know why patients think this, because they know about knee replacements, they know about hip replacements, they know you can treat other arthritis, and yet someone tells them you can't do anything about hand and wrist arthritis. On the ulnar side of the wrist, DRUJ arthritis and pisotriquetral arthritis seem to be the common causes of pain. Here is a patient with more global wrist arthritis, but at the DRUJ specifically, at the red arrow, you can see that the joint is not smooth. You know about non-operative management of arthritis in general, it's not much different, but there are a lot of procedures that can be used for DRUJ arthritis, unfortunately, none of which are ideal, because they all lead to some resection of bone and they don't last quite as long as a knee or hip replacement. So for example, you may have a patient who has a hemiresection of the distal ulnar, and into that gap goes a piece of soft tissue, but that will wear out eventually. Another alternative might be to fuse the DRUJ with an osteotomy of the ulnar to allow forearm rotation. Or you might remove the entire ulnar head so it's not rubbing, but then you can end up with instability of that ulnar shaft. You can do joint replacements, but they tend not to be quite as, they don't endure for quite as long as the larger joints. In the end, what we're trying to do with this sort of arthritis is jolly the patient along as possible so that we can avoid surgery. Pisotriquetral joint arthritis, though, is a little bit easier to manage if it doesn't respond to non-operative management. And that's because the pisiform can be excised. This is a CT scan showing a loss of joint space. Pisiform sits inside the FCU tendon, so it's a very simple procedure to split that tendon and remove the bone. Does it affect mechanics? Yes. Is it better than what the patient was before? Yes. It's a compromise. Now, the last thing I want to mention here is ECU tendon. ECU tendinopathies are fairly common. You will see this in patients where they come in with either a tendinopathy or perhaps subluxation and instability of the tendon, or very rarely a tear in the tendon itself. If the non-operative management does not work, then you have to consider whether or not they need something to stabilize the tendon. This particular diagram here shows a few different types of ruptures of the sheath that holds the ECU tendon in place. And different forms of tears require different types of treatment, different types of surgery. But the gist of this is to get that tendon stabilized within the groove in the ulnar that it's meant to sit in, followed by a rehabilitation program. Once again, proprioception is important, not just pure strengthening, with the ultimate aim to get the patient back to normal activities. All right, there's a few more things mentioned in your handouts down the bottom. I won't cover these because these are much rarer, but bear in mind that there are going to be categories that don't fit into what we've discussed here. The take-home message really from all of this is what you should already know. The precise history and examination are key to forming the right diagnosis and then directing the patient along the right treatment path. Thank you very much.